important because even though patients are on high flow, they should meet the minimum requirement, which is quite obvious because that's usually the minimum which we start them out at. And you again have your PF ratio of less than 300. But this time, in a resource poor setting, they also included SF ratio, which is the SpO2 Fi ratio of less than or equal to 315, which is also known as the Kigali index. And they retained the definition for bilateral opacities for the imaging criteria. But what was new was that they added ultrasound as an imaging modality, especially in these resource limited areas where there's poor access to radiography or CT scans, etc. Um, Again, in the resource limited settings, you do not require the previous definition of having a PEEP of greater than or equal to 5. So in this table, I'm going to show you the reasons as to why the Berlin criteria was updated to the current global definition of ARDS. So if you look at the prior Berlin definition, wherein it was said that the acute onset had to be within a week of known insult, it wasn't truly applicable for the current landscape, especially after COVID-19, because the insults became more indolent. So the inclusion of patients who are now on high flow nasal oxygen of a flow rate of more than 30 liters per minute essentially captured those patients that we were missing with the more indolent courses. And that's how this has been addressed in the global definition. And now again, the previous definition stated that you needed bilateral opacities on chest radiography or CT. Again, in a resource poor setting, can you really have that? You don't. Now, can those patients be excluded as not having ARDS? You cannot. And that's the reason why ultrasound, which is a quick bedside tool, has been used to identify loss of lung aeration. And the three categories, essentially, they've retained the same categories. There was absolutely no change in that, apart from adding the Kigali's index now. And the previous requirement of invasive or non-invasive mechanical ventilation with peak greater than 5 has also been removed, considering the fact that you do not have this sort of equipment available in a resource-limited setting, and also because of the fact that we are increasingly using high-flow nasal oxygen in patients with ARDS. And this basically led to the creation of a new category called the non-intubated ARDS category. Now, in this particular image, we have three patients, and I'm going to go over each patient to see how the global definition is covering these categories. So, your first patient, which is the one on the top, the 68-year-old male with abdominal sepsis, septic shock, and acute hypoxemic respiratory failure. This is your classic patient who's going to present with ARDS. And if you look at the imaging, you see that you have bilateral infiltrates. Now, if you look at his oxygenation parameters, they say that he's mechanically ventilated. You have an FiO2 of zero point 0.5 and you have a PaO2 of 75. So here your PF ratio is essentially 150 and you're in a category of moderate ARDS. Now, typically, this is the patient who would have been captured in your Berlin definition, but this is we're coming to the next case, wherein you have a 54-year-old female, this time with a history of breast cancer, COVID pneumonia, and worsening shortness of breath. As you can see, the X-ray still shows bilateral infiltrates, but she's not intubated. She is not on a BiPAP device. She's not receiving any positive end expiratory pressure. And if you look at her oxygenation parameters, you have the high flow nasal oxygen at 40 liters per minute. You have an FiO2 of zero point 0.8 and you have an SpO2 of 91%. And instead of a PF ratio, we are using the Kigali's index, which is the SF ratio of less than 315. And in this particular case, it's 114. So if we were to follow the previous Berlin definition, she is a patient who would not have been captured under the definition of ARDS. But with the new global definition, she has been captured as a non-intubated ARDS patient. And coming to our third case, wherein we have a 39-year-old female with abdominal sepsis and bacteremia, and she's in a small undersourced, resource-limited hospital, wherein you do not have access to blood gases, radiography, or mechanical ventilation. So instead of having an X-ray or a CT showing bilateral infiltrates, you now have the lung ultrasound, which is essentially Here it's showing more of a B profile, wherein you also have supplemental oxygenation by face mask, wherein you have a flow rate of 15 liters per minute. But based on a new global definition, where even using ultrasound as a modality of imaging is accepted, this patient has been labeled as having ARDS as well. So, this is how the new global definition captures all of these patients that we were to miss with the prior Berlin definition. So coming to the risk factors. So the risk factors can be of two types. It's those risk factors that cause direct epithelial injury to the alveoli versus the indirect risk factors which cause endothelial injury. So if you look at all the direct risk factors, these are essentially the risk factors that cause direct pulmonary insults, pneumonia, aspiration, pulmonary contusions, inhalational injury, and near drowning. Coming to your indirect risk factors, this is your sepsis, trauma or hemorrhagic shock, pancreatitis, burns, transfusions, drug overdoses, etc. So then let's go over the pathophysiology of ARDS. So coming to the pathophysiology, this is absolutely necessary if you are to manage your patients appropriately, given how time sensitive ARDS is. So the first phase that you have is your exudative phase, which lasts from your first day of insult to 7 days. The primary mechanism here is increased permeability, and the reason why this happens is whenever you have the insult, you have all your inflammatory cytokines, including your TNFs, your interleukins, your chemocytokines, etc., which increase the permeability of the alveolar capillary membrane. Now, when you have a break in your alveolar capillary membrane, you initially have your interstitial flooding, followed by fluid accumulation in the alveolus. Now, this presents a severe hypoxemia, decrease in your lung compliance, and also shows bilateral infiltrates. Coming to the next two phases. So the next phase after the exudative phase is your proliferative phase. Now your proliferative phase is from day 7 to day 21. And the reason why this has been named as proliferative is because it is in this phase that you have active type 2 pneumocyte proliferation. You also have fibroblast activation, and you also have organization of your edema in the alveoli. So what happens here is you have partial alveolar repair and you have some interstitial inflammation. In this particular phase, you have some improvement, but some patients can also progress into the fibrotic phase, and that's what makes ARDS so difficult in some patients. Wherein more than 3 weeks, this phase of for the fibrotic phase happens more than 3 weeks into the initial insult, wherein you have collagen deposition, you have lung modeling, you have fibrosis. And this basically causes stiff lungs, it causes prolonged ventilation, and this is primarily responsible for also causing group 3 pulmonary hypertension. Now, coming to the role of cell-free hemoglobin, now this is something that is quite nuanced. It's quite new in the ARDS picture. So, what cell-free hemoglobin is whenever you have endothelial injury, which causes early capillary permeability, your alveolus is flooded with proteinaceous fluid along with leukocytes and RBCs. Now, when your RBCs lyse, that's when you have a release of your cell-free hemoglobin, which is quite toxic. This also causes the activation of the toll-like receptor 4 that induces further inflammation from leukocyte adhesion. And the role of cell-free hemoglobin, again, as I said, it's quite nascent, and people are still looking into how this is going to impact ARDS. Now, coming to the mechanics of ARDS. So the mechanics of ARDS, this is something that is absolutely essential to understand if you have to manage ventilation in ARDS. So I'm going to go over a few key concepts that one needs to absolutely know and understand before we can go into each of the treatment modalities. So the first concept, the historic concept, is the baby lung in ARDS. So the functional recruitable lung in ARDS is much smaller than normal. So if the standard tidal volume is 500 ml, which doesn't cause strain in a regular lung, the same thing can cause a lot of strain in an ARDS lung. Now, the stress, which is basically a representation of your pressure. The transpulmonary pressure, it represents the true descending pressure acting on the lungs. separating lung parenchyma stress from chest wall resistance. I'm going to go over each of these in the next one, in the next slide with a balloon so that it's easier for you to understand. So these are just the definitions. If anybody's having difficulty understanding this concept right now, I'm going to clarify it in the next slide. So then coming to the strain. What the strain is basically how much of deformation is happening in the alveolus. As you can see, the formula is change in volume over FRC. And high strain can cause epithelial stress fracture and it can cause ventilator-induced lung injury. And then you again have dynamic strain versus static strain, wherein you, with dynamic strain, which is caused by tidal volume, is much more damaging to the lung tissue. The reason being, every single time you have tidal volume going in and coming out, it causes the alveolar stretch. And that is more damaging than the static strain you cause by keeping the alveoli open through P. And the other key concept, which is how ARDS is driven these days, is with your driving pressure. Now, your driving pressure is the difference between your plateau and your peak. The plateau is basically a representation of your lung compliance, which you can obtain by doing an inspiratory hold on the ventilator. And it's essentially the driving pressure is the pressure required to open up the alveolar sacs. And the target that you should aim for is less than 15. Now, this is a quick explanation of what lung stress and strain is. And I want you all to imagine two balloons, and that's how you can imagine what's going on. So, the same force, let's say you have balloon A, which is the blue balloon here, and you have balloon B, which is the smaller one. Now, balloon A is your regular lung, which is large with a high FRC, and that's how your lung is. And balloon B, that's the smaller one, which is your ARDS lung, aka the baby lung. Now, stress is equal to pressure. So the transpulmonary pressure is going to differ from balloon A to balloon B. Now, let's say that you put the same amount of air in balloon A and the same amount of air in balloon B. Now, because your balloon A or your normal lung has a very good compliance, it expands quite easily and stretches a little, causing low strain. Whereas your red balloon, which is your ARDS lung, which has a very poor compliance, stretches a lot with the small tidal volumes that you're giving. And this causes the high strain in these conditions. So, the same human example that you have down below, if you can see with the same lungs, you have two different strain values, wherein with the healthy lung, you have a strain value of 0.20. And with an ARDS or a baby lung, you have a strain value of 1. And that's the reason why we go for low tidal volume ventilation in ARDS. And this is the next key concept that I want everybody to understand is that one PEEP doesn't fit all. And we now have the concept of mechanical power, which is the total energy transferred from the ventilator to the respiratory system per unit time. So the mechanical power formula, as all of you can read it, you have two different formulas. One is in volume control and the other one's in pressure control. And here in the formulas, the 0.098 is basically the conversion factor for joules per minute. But the key factor that everybody should notice, and what we as lung physicians have been missing out in the past, was the addition of the respiratory rate. Now, historically, when we had low tidal volume ventilation and we had patients becoming hypercapnic, because our hands were tied with the limited tidal volumes, we used to go up on the respiratory rate to counteract the hypercapnia. But with mechanical power, we have to make judicious use of our respiratory rates as well and make sure that we don't exceed the safe value of 17 joules per minute. Now, there's no definitive safe threshold. There have been values ranging all the way from 17 to 18.7 joules per minute. But as of now, the universal consensus is around 17 joules per minute. Then coming to your phenotypes of ARDS. Now, it's based, these ARDS can be phenotyped based on your clinical features. It can be classified on the basis of your lung injury, biomarkers, etc. But the two most important things that we have to remember, at least from the practical aspect, is hyperinflammatory ARDS and hypoinflammatory ARDS, and also pulmonary ARDS and extra pulmonary ARDS. So is phenotyping really necessary? Why is it that we need to know what sort of ARDS it is and why every ARDS is not the same? So here, if you look at this slide, I have the differences between pulmonary ARDS and extrapulmonary ARDS. So pulmonary ARDS, this is your direct injury to the alveolar epithelium, whereas with extrapulmonary ARDS, you have injury to the capillary endothelium. And the going to the next one, and the others you can read, but the other major difference is your radiological pattern, wherein pulmonary ARDS, it's usually more of a consolidation predominant pattern versus the ground glass predominant, which is in the extrapulmonary ARDS group. Now, the recruitability again is an important factor, as you see here. In pulmonary ARDS, recruitability is low compared to extrapulmonary ARDS, wherein you have a higher recruitability. So then coming to your lung elastance as well. So your lung elastance is greater in pulmonary ARDS compared to extrapulmonary ARDS. And the other important thing is your response to PEEP. So there is an overdistension risk which predominates recruitment in pulmonary ARDS, but in extrapulmonary ARDS, recruitment precedes overdistension. So additional PEEP is more helpful in extrapulmonary ARDS rather than pulmonary ARDS. And even coming to prone positioning is less helpful in pulmonary ARDS compared to extrapulmonary ARDS. So now coming to the treatment part of ARDS, this is just a very broad overview as to what we're going to be talking about. But I'll start with the first two things, which is the strong recommendation against. So we right now it's strongly recommended to not do recruitment maneuvers and to not go for high frequency oscillatory ventilation. The oscillate trial completely killed HFOV, so we're not following that anymore. We have conditional recommendations for neuromuscular blockade, VV ECMO, systemic corticosteroids, and high PEEP. And we have a strong recommendation for lung protective ventilation and prone positioning. So this is the broad overview of the topics that we're going to talk about in treatment. So starting with the fluid strategy, historically, we've been taught to keep ARDS patients dry. But what is the true reason as to why that was needed? So acute circulatory failure is also highly prevalent and prognostic in ARDS patients. And optimal fluid management, it remains quite challenging. So there was one trial which shaped this, and that was the FACT trial in 2006. I think somebody's mic is on. I'm having a lot of disturbance. So if somebody could just mute their mic. Thank you. So coming to the FACT trial, and this was in 2006. So here in the FACT trial, they tested a conservative versus a liberal strategy of fluid management, wherein the 7-day fluid balance in the conservative strategy was net negative 136 ml compared to close to a positive 7-liter strategy in the liberal strategy. And the conservative group had higher oncotic pressures, lower intravascular pressures. And again, if you look at how the results were, the 60-day mortality was around 25% in the conservative strategy versus 28% in the liberal strategy, though the p-value was not significant. It was the ventilator-free days that were actually statistically significant. And if you also look at the PF ratio on day 7, the conservative strategy had a higher PF ratio compared to a lower one. And the reason being that if you overload patients with fluid, that could cause pulmonary edema, further decreasing lung compliance, and further decreasing your oxygenation, etc. And this is the next major thing, again, I reiterate this again, that one size doesn't fit all. So ventilator management previously was guided by our ARDS net tables, but in today's day and age, one size doesn't fit all. Every patient needs tailored individual mechanical ventilation strategies, and I cannot stress this enough. So if you look at each patient, their compliance might be different. Whether they have pulmonary ARDS or extrapulmonary ARDS also makes a difference. So don't presume, make sure that you always know what your mechanics are and how you're actually ventilating the patients. So coming to mechanical ventilation, which is the major part of ARDS. Now, the ARDS network trial, this was pivotal in establishing the new approach wherein they said that high tidal volumes actually cause an increase in mortality. And this is when utilizing a lower tidal volume strategy of 6 ml per kg of ideal body weight significantly reduced the mortality. I put in the peak titration table here, but honestly, in today's day and age, it's not really necessary. So where did the number 6 cc per kg ideal body weight come from? So this came from the landmark ARMA trial, wherein they enrolled 861 patients across 10 centers, comparing 6 ml per kg predicted body weight, targeting a plateau pressure of less than 30 centimeters of water versus 12 ml per kg PBW. And this trial was stopped early for benefit, wherein you had a statistically significant reduction in mortality from 39.8% in the high tidal volume group compared to the 31% in the low tidal volume group. And you also had more ventilator free days in the low TV group and more organ failure free days in the low TV group. So why 6 cc's per kg body weight? Why not 7? To be honest, this number was rather pragmatic. There is no physiological derivation of this number. And even if you look at the ARMA protocol, the mean that was used was around 6.2 ml per kg. So it's not exactly set in stone that it's 6 ml per kg. It allowed reduction all the way up to 4 ml per kg. So there's absolutely no evidence that 6 is superior to 7 or 8. But the trial suggested that tidal volumes of 8 or greater were associated with significant mortality. And that's the reason how we've come to this number that we have to start patients with 6 cc's per kg body weight. This is a table that I took from our previous ARDSnet, but as I said, mechanical ventilation therapy in today's day and age is tailored, so we're not going to follow this table anymore. So historically used global parameters such as tidal volume and driving pressure, they fully do not capture the heterogeneous pathology of ARDS. And that's the reason why our newer concepts like mechanical power, compliance-based ventilation, and transpulmonary pressures are more promising avenues of personalized care. So in this particular slide, what I've included here is electrical impedance tomography. And the way this works is you have a belt around your chest wall. It comprises of around 16 electrodes, which give you electrical signals based on your regional pattern of ventilation. So the color gradient, it usually goes from black to yellow. Black meaning that there's no ventilation, and yellow means that you have ventilation in those regions. So as you're increasing your PEEP to recruit more lungs, it can actively show you whether you're over distending regions of some lungs or if you're able to homogeneously distribute the PEEP. So this helps in PEEP titration as well, but this is something that's used in highly advanced university centers and is not available to every hospital. So proning, this is something that has time and again proven mortality benefit for our patients. And for us, the prone positioning is a cornerstone adjunct. And the reason why it's helpful is because whenever you prone a patient, you decrease your thoracopulmonary diameter. Um, sorry, your thoracopulmonary distance, and the weight of the heart is lifted off the posterior part of your lungs, and that allows you to have more ventilation into those areas. So this is based on the Proceva trial that came out in 2013. So it was a multi-center prospective RCT wherein you randomized 466 patients with severe ARDS, and their inclusion criteria was that you needed to have a PF ratio of less than 150, an FiO2 of zero point 0.6, and a PEEP of greater than 5. The proning was carried out for 16 hours a day with lung protective ventilation. And the 28-day mortality, as you can see, was 16% compared to the 32% in the supine group. And even the 90-day mortality was low. So the conclusion was early, and again, I say early, prolonged proning significantly reduces mortality in severe ARDS. Usually we prefer having these within 36 hours of the diagnosis. So this is a rotaprone bed that we used at the university. So as you can see here, the patient is in the center of the bed. Unfortunately, it's not visualized that well. So the rotaprones are set, they're timed, wherein the beds automatically turn into the prone position for 16 hours and they go back into the supine position for 8 hours. And in case of any care that's needed for the patient, we're still able to do it with the patient's prone. So these are the other available devices that we use, and what we have here is an esophageal manometer. And one of the main reasons as to why you need an esophageal manometer is in patients with ARDS who have intra-abdominal hypertension or poor compliance because of an obese chest wall, your plateau pressure is going to be high, regardless of what your transpulmonary pressure is. And you really don't know if the poor compliance is because of intra-abdominal hypertension, is it because of the thick chest wall? So if you drop in an esophageal manometer, it gives you, it reflects the esophageal pressure, which is a direct reflection of your pleural pressures. So this directly gives you the transpulmonary pressures, and you're able to better interpret your lung compliance with these devices. So in cases wherein you have such patients with either intra-abdominal hypertension from pancreatitis, or if you have an obese patient, this device is quite useful. Then coming to the concept of neuromuscular blockade. So historic rationale. They said that it improves ventilator synchrony, it prevents patient self-induced lung injury, it also promotes homogeneous ventilation, and that was the rationale for neuromuscular blockade. Now, there were two landmark trials which investigated the use of neuromuscular blockade in ARDS. One was the Accuracies trial in 2010, and the other one was the ROSE trial done in 2019. So if you see, both of them used Nimbex or cisatracurium for 48 hours. But if you look at the sedation protocols for both of them, the sedation protocols are the difference. So in Accuracies, all of the patients had deep sedation compared to ROSE, wherein your patients had lighter sedation. The primary outcome that they looked at was the same in both the trials, which was the 90-day mortality. And the primary result was that the accuracies suggested benefit, wherein the 28-day mortality was 23.7% compared to 33%. But the ROSE trial, it showed that there was no benefit in modern ARDS care. Now, the reason why this happened is the time period. In 2010, the management of ARDS was not as advanced as it was in 2019. Protocols were not tightly followed of low tidal volume ventilation, and even the sedation strategies were not that great. So, because the sedation strategies were not great in ARDS, when you gave them a neuromuscular blockade, they were able to better achieve ventilator synchrony, and that could potentially have decreased the mortality. All of that with Rose, because we had better sedation strategies, we did not find any benefit. So finally, should patients receive neuromuscular blockade? The 2024 guidelines from ATS, they recommend using neuromuscular blockade in patients with early severe ARDS. Again, it was a conditional recommendation. Then in 2026, recently in March, the Society for Critical Care Medicine suggested using a neuromuscular blockade in patients with ARDS with a PF ratio of less than 150 who are persistently hypoxemic, not achieving mechanical ventilation targets. And the reason why there is more of a recommendation to use it now is because although the largest trials didn't demonstrate a huge benefit, more pooled data from 7 RCTs demonstrated a possible reduction in mortality and an increase in ventilator free days, prompting the recommendation in favor of highly selective neuromuscular blockade use. And we use this only for 48 hours, and the neuromuscular blocking agent that we prefer is cisatracurium. And the reason why we prefer cisatracurium over the others is because cisatracurium is the only neuromuscular blocker which undergoes Hoffman elimination. So it's not dependent on either hepatic elimination or renal elimination, both of which can take a hit in ARDS. So this is the safest to use. And some recent trials also say that there is an anti-inflammatory effect of Nimbex, but that's not been proven. Coming to the other controversial topic for ARDS, which is your steroids. So these are anti-inflammatory medications. Multiple trials have assessed the efficacy, and the 2024 guidelines suggest using corticosteroids for patients with ARDS. So one of the landmark trials that came out, DEXA ARDS, came out in 2020, wherein you had patients with moderate to severe ARDS, and it showed that there was a significant reduction in ICU mortality. The protocol they followed was 20 milligrams of dexamet for 5 days, followed by 10 milligrams for the other 5 days. And this was another historic trial, and this came out in 1998, done by Meduri. I had to include this because this was done at UT, and that's where I did my fellowship from. So they use instead of using the pulse dosing, they used continuous infusion of methylprednisolone, and even they suggested that the mortality was low, although this was a very small study and the sample size was only 24. So these results were taken with a grain of salt at that time. And currently, two large trials are underway. One is the GUARD study, and the other one is the CORTED 2 study. And these are also looking at corticosteroids, wherein the CORTED 2 is actually looking at a prolonged steroid use. So if you look at the CORTED study, which is on the right, it's initial corticosteroids for 10 days, followed by reassessment, and then doing steroids for another 10 days. So once both of them are finalized, they'll be good topics to discuss as well. Then the other topic is inhaled nitric oxide. So it's a selective pulmonary vasodilator. As it reaches only ventilated alveoli, it dilates the pulmonary vessels, thus improving your VQ matching. Key things to remember: it does not reduce mortality, does not decrease the duration of mechanical ventilation, does not decrease the ICU length of stay. What are the hazards? AKI, most common, methemoglobinemia. And if your down titration strategy is not proper, you can cause rebound pulmonary hypertension. So the key pearl to take away with inhaled nitric oxide is think of it as a bridge therapy, not a destination. It can transiently improve oxygen. It can buy time for interventions such as proning, lung protective strategies, initiation of VV ECMO, etc. But it does not reduce mortality. Then coming to veno-venous ECMO. So veno-venous ECMO, as we know, facilitates oxygen and CO2 removal by draining blood from the venous system. It's an invasive and quite resource-intense technology, but it comes at a significant cost, both monetary and human. And the use of VV ECMO has increased, especially with the onset of viral pneumonias over the last couple of years, including the H1N1 pandemic in 2009, followed by the COVID-19 pandemic that we had in India in 2020. And these were the two trials that looked at it. One was the EOLIA in 2018, and the other one was the CESAR trial in 2009. So I know there's a lot of information on this slide, but I'll direct you to the most important things here. So look at the interventions between both. In EOLIA, the intervention was early VV ECMO. In the CESAR trial, the intervention was a referral to an ECMO center. It was not that every patient in the intervention group got ECMO. They were referred to an ECMO center. Conventional group, again, the conventional lung protective ventilation in the EOLIA trial was strictly protocolized. And in the CESAR trial, it was not protocolized. The crossover in the EOLIA trial was extremely high. So there was a lot of crossover from the control group into the intervention group, which was the ECMO group. And finally, the mortality outcome, 35% was the mortality in the ECMO group compared to 46% in the control group. Now, finally, when the results came out, the CESAR trial showed that ECMO had a significant benefit and EOLIA did not have a significant benefit. So you could be having that question as to why these two trials, both of which looked at ECMO, have contradicting results. And the reason being the interventions themselves. So if you look at the CESAR trial, one, the control group was a less standardized group. So conventional ventilation was followed at a lot of the non-ECMO centers. So when these patients were referred to an ECMO center wherein physicians were using proper lung ventilation strategies, that significantly brought down the mortality. But again, the EOLIA 2 is not perfect the earlier, if you look at the mortality, it did have a reduction in mortality, 35% in the ECMO group compared to 46. So there was 11% reduction in that. But the reason why it was labeled as not statistically significant was because it had a p-value of 0.09. And the reason why that happened is because the way the sample size was for this trial was not enough. For the power that they had calculated for the study, they needed a sample size which was much larger than this. But because the sample size was only close to 250 patients, it showed that this was not statistically significant. But in today's age, we use ECMO for patients who qualify. So these are the indications as per our ELSO. The indications for ECMO, so PF of less than 150, effort of zero point 0.9, Murray score of 2 to 3, etc. The indications you can read. Um, Contraindications, again, aggressive mechanical ventilation of FiO2 of zero point 0.9, P-plug greater than 30, and all of these contraindications, they're not absolute, they're just relative contraindications. Hemorrhage in the CNS is an absolute contraindication. So the age, again, no cutoff value. But here I'm going to give you the diagnostic groups and how we score. And in my fellowship, we were an ECMO center. So we used to decide as to which patients to take for ECMO and which patients we were not taking for ECMO. And this is how we used to decide. So we had categories: favorable, high risk, and unfavorable. And if your diagnosis included something like pneumonia, aspiration pneumonitis, status asthmaticus, PGD, ARDS, you got a score of +1. Something like necrotizing pneumonia, vasculitis, lung transplants in the 7 to 30-day group, traumatic lung injury, moderate traumatic brain injury, ARDS and chest trauma. You were in the high risk group. You did not get a score of +1. You got a score of 0 to -1. And then you had the unfavorable group, which gave you a score of -2 to 3, which is ARDS from non-pulmonary causes, invasive aspergillosis, PJP, lung transplant more than 30 days. Same thing with your comobs. If you had acute clinical conditions like a lactate of above 5, noradrenaline more than zero point 0.3, ischemic hepatitis, and urea, you got a score of +1. Even chronic comorbidities got a score of +1. And then finally, we used to put the score in this table. And as you can see, with increasing age, your prognosis becomes poor. With an increasing score, your prognosis becomes poor again. So our criteria for acceptance was patients who came either in the green or the yellow group. So the current recommendation is we suggest the use of VV ECMO in selected patients as per the criteria I mentioned in the previous slides. So this is a quick recap of everything that we had. So steroids, yes, recommended. VV ECMO, if you find the right patient, yes. Neuromuscular blockade within the first 48 hours of mechanical ventilation with a PF ratio of less than 100, yes, do consider it, and please use cisatracurium. High PEEP strategies, yes, totally recommended, but please keep your driving pressures in mind. And this was the present. So what's in store for us in the future? We are investigating mesenchymal stromal cell therapy. Um, so these basically modulate immune function. They help in repairing barrier function, and they also exert an anti-inflammatory and anti-apoptotic effects. But again, this is in a very, very early stage, and we do not have any data on this. Some of the data that we do have right now that came out in JAMA in 2025 is from the active trial, which looked at closed loop ventilation, wherein you had intelligent adaptive servo ventilation modes wherein the systems continuously auto-adjusted tidal volumes, rates, PEEPs, and FiO2. It showed equivalent ventilator-free days with improved ventilation quality, reduced manual adjustments, and better adherence to lung protective strategies because this was all AI-driven. But we do not have any hard outcome benefit yet. More larger RCTs are going on. So in the near future, we should have better data regarding this. That was the last of my slides. So remember, driving pressure, please keep it low, and that will help you drive safe in ARDS. So that was my slides. So I'm open for any questions that you have.
Excellent presentation, Dr. Nishant. Covered everything
Okay.
from aspects definition to global definition.
Mhm.
All parts you have covered, and Thank you very much for that. I request audience to open for discussion. Any queries? Hello?
Good morning, Nishant.
Good morning, Dr. Maharaj.
Yeah, thank you very much, and excellent presentation with good PPT and good word battle. And what is the
Thank you.
future of ARDS? What do you think? And as a phenotype and genotype. And second time, all the time, I get a second question is that every time Dr. Ravindra Babu Gundanpalli always thinks that the outcome of ARDS is percentage of the p value is different. Why can't it be that way? That's what he keeps asking. So these are the two things I just highlighted out. Thank you.
Okay, I just didn't get the second question.
I think better Dr. Ravindra Babu asked that question. Sir is there in the line. Anyway, I'll ask only my
Oh,
question. What is the future of ARDS and what is the phenotype and genotype? Those things is going to be because in our team, the
okay.
Dr. Varalakshmi always talks much about the precision medicine and good. That's why.
Okay. So coming to the phenotyping and genotyping of ARDS. So again, if you look at the biologic genotypes, right, you have the hyperinflammatory phase and the hypoinflammatory ARDS. These are the two genotypes that we have. So the hyperinflammatory genotype, it's more interleukin driven. There's a lot of IL-6, IL-8 release, and you have more organ failure, and it's associated with a higher mortality. Now, do the strategies remain the same between the hyperinflammatory and the hypoinflammatory group? Yeah, the strategy is the same. If you're thinking that you could use agents like anti-IL-6 in the hyperinflammatory group, it's not recommended. The use of IL-6 inhibitors have been studied only with COVID-19 ARDS, unfortunately. Yes, in theory, could you use that in hyperinflammatory phenotype? Probably yes, but we do not have any evidence supporting that. Coming to the other one, which is your extrapulmonary phenotyping based on extrapulmonary and pulmonary ARDS, the only reason why you would have to keep that in mind is to know what sort of recruitability you're going to have and whether PEEP is going to have any benefit or not. So in extrapulmonary ARDS, you're going to have better benefit by using PEEP because there's more recruitable lung compared to your pulmonary compared to your pulmonary ARDS, wherein recruitability and PEEP is an issue. So increasing your PEEP might not exactly help you recruit more lung in that.
Dr.
Nishant,
Nishant. Okay, correct.
Nishant, nice talk. Now I can
Thank
say
you.
Prem Kumar was your father rather than your Prem Kumar. But you have to reach a lot of heights to equal your
Mhm,
father. So
mhm,
my question is, see, suppose for mechanical power, you have to reduce
mhm,
the respiratory rate. For
mhm,
example, when you deal with a severe ARDS case where you go for, say, 4 to 5 ml of kg tidal volume of, you have to put a more respiratory rate.
mhm.
Then automatically the CO2 climbs. So in
Yes.
our institution, how much pH you allowed to go down?
So our
Is it
cutoff is
7.25 or
7.2.
7.15?
So we strictly follow 7.25. So for us, acceptable is 7.25.
So even AirDust trials said you can allow 7.15 and
Mhm.
then combine it with bicarbonate. Because I don't think with severe ARDS going for 4 ml and controlling the rate, you will achieve a 7.25. It is impossible. Because
Yes,
for
so
every
7.25 is
10, the
impossible.
point it goes. So
Yeah, so
most
we
of the patients will have definitely less than 7.25.
Mhm. So
Mhm.
7.25 is again, it's an institutional driven protocol and more of a physician driven protocol. Yes, you can accept 7.15 provided that's not causing an effect on any of your vasopressor action or anything like that. Again, if you were to look at the exact numbers, and again, if I have to comment on the use of bicarb in those patients, whenever we're using bicarb in ARDS patients, again, if especially these patients are patients who have type A lactic acidosis, whenever you give bicarbonate in those patients, it again dissociates into H2O and CO2, causing hypercapnia. So if you're at the limit of your respiratory rate, you're in a really hard spot, because again, if you give bicarbonate, you will induce hypercapnia. So the problem with now following your mechanical power is you have more patients who either need ECOR, which is extracorporeal CO2 removal, or ECMO. So that's what's going to happen in the future when we start following driving pressures more accurately. It's not driving pressures, mechanical power more accurately.
That is okay for countries like you, but still
Mhm,
in many of the medical colleges, even they don't put the patients in a prone position. Forget about the ECMO
mhm,
and all that. So I'm
mhm,
talking about this. So anyway, my next question is, see the alternate trial.
mhm,
See, there is a difference of only 9%.
mhm.
See, in the less than 30 p-plat group, 30, let us say 31% mortality is
31
there.
was the mortality, yes,
Mm.
yeah.
In the other group, where it exceeded
Mhm,
more than that, there is a
mhm.
mortality of 40%.
Yes.
See, my point is, see, in spite of high plateau pressures,
Mhm,
60% survived.
mhm,
And you think of the other way, you understand?
mhm.
So in spite
Yeah.
of the high pressure, see, if 100% die with high tidal volumes and high plateau, that is a different
Mhm.
affair. So even with
Yeah.
the high plateaus, 60% survived.
Mhm,
So what I want to say is, in a case where you don't have a rescue therapy like ECMO or all that, why don't you go
mhm.
beyond the 6 ml tidal volume and increase the P plats, because that
Yeah.
increasing it will raise the mean airway pressure and improve the oxygenation
Yeah.
as a rescue therapy. You understood my point?
Yeah.
Because
So
the
as a
other way
rescue
around,
therapy,
I saw nobody discussing about that. See, in spite
yeah.
of
So as a
high,
rescue therapy, could you do that? Yes. So as I mentioned previously, even in that trial, that 6 ml per kg, it's a very pragmatic number. To be honest, even they didn't follow the 6 ml per kg body weight accurately. The mean ml per kg body weight was 6.2. So, as you aptly said, there were some patients who were ventilated with a higher tidal volume of 7 and 8, and they did not find any difference. So, if needed, yes, I do agree with you that you could go up to a higher tidal volume.
that is what I'm saying. Because I see
Mhm,
many patients, they are still put on 6 ml or 5 ml kg body weight, even in spite of not progressing, because
mhm,
they think they are following the guidelines. That is what I'm saying.
Can I come
mhm,
in at this moment?
Sure.
Yeah. As Dr. Ravindra Babu said, when there is nothing is there,
Hmm.
there is no further
mhm,
avenues. You jump into the river which has crocodiles. Absolutely. Because the
mhm,
tiger is driving you or it will be devouring you. So you jump into it.
mhm,
We don't know what happens. That's what he said. See, we don't have, as it is, low tidal volume strategy. Why not high tidal volume strategy? High tidal volume strategy increases the plateau pressure, increases the risk of barotrauma, alveolar rupture, interstitial edema, pneumomediastinum, pneumothorax. All such things will happen, barotrauma. And sometimes increased volumes may compress the intraalveolar capillary and the blood flow and the gas exchange may be impaired. Over distension can reduce the compliance again. See, you see the compliance only at a particular tidal volume, it will improve. Even at the lower VT, even at the higher VT, the compliance decreases. It's a bell-shaped curve, isn't it? So, increasing the tidal volume, accepting higher plateaus, these are all the problems. But to counter that, we are using the low tidal volume. If it is not possible, we are accepting the permissive hypercapnia strategy. And even then, it's not, we are going for ECMO. If all these things are not there, Why allowing people to die with a low tidal volume strategy? That is his question. I agree, but all these caveats, barotrauma, everything keeping in mind. Thank you. And
Sir, one
your
small thing, sir, Prem Kumar, sir, as you rightly
please,
said.
please.
One small thing, Prem Kumar, sir, as you rightly said, agreed everything. But only thing is, the concept of stress and strain is the main thing for this all these things. So when your tidal volume is reduced, we know the concept. So automatically that physiology and pathophysiology, when you're correcting, that is more important for us. So why do we think about high tidal volume? Is the
No,
thinking, sir.
finally, what
Hey,
Dr.
what?
Ravindra
See,
Babu is saying is, what is the anyway, any trial or any drug, the end result or end parameter should be mortality. So here the mortality has been reduced to some extent. When nothing is there, no avenue is there the ECMO is not available, nothing is there, then he says accepting the barotrauma and all. See, stress and strain indirectly translate to barotrauma, isn't it? What the stress and strain? Stress and strain are physiological numbers. What is the result? Barotrauma. What is the result? Mortality, complications. So I agree, but when there are no other avenues to go forward, I think accept something.
Sir,
Mohan Maharaj,
sir,
please.
hello, sir.
Yes, sir. Yes, sir.
Sir,
Because I
Just
just want the people, so many people, Jekin
sir,
Srinivas,
good
Rani
morning.
Madam, Varalakshmi, so many
Sir,
seniors are there in the group, they can talk.
Mohan Maharaj, just one
sir,
thing.
good morning.
See, all the factors you said, they were there in the ordinance net trial. See, just look at how many percent of the people survived. 60% survived in spite of all the factors you mentioned. Even the barotrauma is same in both groups. The pneumothorax factor is same in both groups. But 60% still survived. That is what I am saying. When you don't have the other rescue, these things, just allow more tidal volume and allow more plateau pressure. That is what I'm just saying. Instead of killing a patient, putting on the 6 ml or 5 ml per kg body weight as per the guidelines.
Sir, good morning, sir, Ravindra Babu, sir. Sir, we can try one thing is before accepting a high tidal volume, we can try prone ventilation, sir. It's a easy
No, no,
thing
after prone
and
only. See, after prone only, I
prone
am
ventilation.
saying. These rescue therapies, when you try everything, definitely only after proning and other things only, neuromuscular blockade, etc., etc.
And if you cannot go for ECMO.
ECMO. That is what I am saying. Because
Yeah,
everybody cannot afford ECMO. Because
yeah.
I see in a lot
And
of these things, they follow guidelines. You just put the 6 ml or 5 ml kg body weight and then let the patient die. No,
yeah.
that is not the
So
way. The
I
increasing title, you look at the figure, not about the mortality. You look at the figure, 60% survived in spite of more plateau pressures. That is important. If
so
100%
again
die,
I
I
just
will
want
accept.
to yeah.
Anyway,
So yeah, I'm going to jump in again, and I totally agree with Dr. what Dr. Ravindra Babu is saying. And again, as I mentioned in the ARDS trial, the 6 ml per kg that they derived was a pragmatic number. There is no physiological evidence behind that number. So in a Hail Mary situation, when you have to use a higher tidal volume for blowing out CO2, yes, if you have to do it, you have to do it. So yeah, I
okay.
agree with that.
Okay, thank you, thank you.
Mhm.
Dr. Nishant, Dr.
Yes,
Nishant,
okay.
as per this new concept of mechanical power,
Mhm.
once respiratory rate is the main criteria nowadays. No,
Mhm.
because the Arsenal's protocol is telling you can go up to even 40 respiratory rate when
Mhm.
permissive apnea is maximum up to 7.15.
Mhm.
So, what rate your in your center is going maximum respiratory rate?
So respiratory rate, the maximum that we have, again, it's very physician driven. We accept rates of anywhere between 35 to 40. But again, if you look at the mechanical power formula, every single time you go up on your respiratory rate, you're basically sending in more power units to the lung. And so what we aim to do is we try to keep the mechanical power around 17, but again, we do have an upper limit of 18.7 joules per minute. So we try going up to that. But if it's exceeding 18.7, that's our limit. Like after that, they have to go in for therapies like ECMO.
And adjust the rate. It's not the number.
Yeah, it's not based on the number. We don't have a hard target, but if we in our practice, we haven't reached 40. We what we do is we go up to 35. Usually 35 is our max because we have a lot of problem with auto peeping when we're going up above 35. At that time, sometimes based on the lung mechanics, like how Dr. Ravindra Babu said, that this is a time when you could potentially go up on the tidal volume to see how it affects your respiratory mechanics. If you're going up slightly on the tidal volume and your plateau pressures are still below the 30 number that you want it to be, you're potentially good. Or you can have a higher threshold of 18.7 because again, 17 is not a number set in stone for mechanical power. So this is how we allow it. We let it go up to 18.7. If it's going above 18.7, there's nothing that we can do about the hypercapnia. Then we send them for extracorporeal therapies.
Do you have your
As
ventilator's mechanical power depicted on the screen, or you calculate, Dr. Nishant?
No, we have to calculate it.
Okay. Do you adjust the PEEP
Yeah.
according to the ultrasound or any other method, or any scalars and this one?
No, so most of to be honest with you, doing this mechanical power equation when you have a lot of patients with ARDS is hard. I would say that the most easiest thing to do is based off of the driving pressures. So most of our peak titration is based off of the driving pressures more than anything.
And you check lung injury score regularly through ultrasound, Dr. Nishant?
No, not exactly. We haven't seen much benefit by doing that. Instead, for us, it's more of a driving pressure trend that we follow. So the way it works is the RTs throughout their shift here, they keep charting the driving pressures. And sometimes if it's a patient that's too difficult to manage, we do drop in an esophageal balloon and we keep a trend over the transpulmonary pressures, and that's how we usually optimize PEEP. So we have an end expiratory transpulmonary pressure and we have an end inspiratory transpulmonary pressure. So the end expiratory transpulmonary pressure, we aim to keep it around 2 to 5 centimeters of H2O. And your end inspiratory pressure, we keep it around 20 to 25. So in your end expiratory pressure, if it's going into the negatives, that means that our patient needs more PEEP. And in our end inspiratory pressure, if it's exceeding 25, that's the time when we decrease the PEEP. So I feel that the esophageal balloons are, a really resourceful tool in these conditions where PEEP titration is hard. And that's how we usually do it whenever we have issues with PEEP titration, which is using esophageal balloons.
Yeah, very nice, because the cost is the issue here, but very, very nice. Thank you
Mhm.
so much. I'm done because I give a lot of seniors are there in the class, so they can discuss. Thank you
Okay.
very much, Nishant.
Thank you. Thank you.
if you don't
Any,
have a balloon, esophageal balloon to monitor the transpulmonary pressure,
uh-huh.
what PEEP, maximum PEEP you will go up to?
So the maximum peak, to be honest, again, there's not a lot, and it's purely patient driven. Have we gone up all the way to 20, 25, beyond 25? Yeah, in some cases. But unfortunately, for me, with the practice that I've done, with the amount of resources that we have never blindly titrated PEEP. So unfortunately, I don't think I'm the best person to give that answer.
Yeah.
Yeah, and again, for the peeps, if you look at it again, if you're increasing peep, you also have the problem with regional distribution as well. So just go based off your driving pressures. That's all I can say. So if your driving pressures are less than 15 with your current peep, I think that should be okay. The other biggest thing that people tend to forget in patients with ARDS is, don't always anchor yourself to ARDS itself being the cause of hypoxemia. Every single time your patient is even more hypoxic in ARDS, think of all the five causes of hypoxia again for each patient. So you never know whether this patient could have developed an additional PE that could also have caused this. So please think about all the other five causes of hypoxia as well.
Yes, sir. Okay. Any
Any
queries
other
from audience?
questions?
So
Hi,
regarding the
Dr.
PEEP,
Nishant.
see, one of the
Uh-huh.
one of the factors that is responsible for our PPLAT is the chest wall pressure, apart from the
Mhm.
transvalvular pressure. So what they advise is, whenever you expect a high intra-abdominal hypertension or a very obese patient, then go for the higher PEEP table rather than the low PEEP table. Because there you should use more PEEP and allow the more, when you use more PEEP, automatically the PEEP goes up. But it doesn't matter because the transvalvular pressure will not go up.
Yeah, so
Because
this
we
is
learned that the
exactly,
esophageal pressure balloons. So that is what
yeah,
is
that's the
advised. Go
problem.
for the higher PEEP table.
Mhm. Yeah, the only problem is, there is always a chance that you can over distend the lung because it's not a true measure of compliance. But I guess when there's no other alternative, then yeah, you can do it.
Hi, Dr. Nishant. Can I ask
Hi,
something?
Rani. Yes, please.
Hi. Yeah, you're on prone position mechanical ventilation, and you've already given neuromuscular blocker, and your
Mhm.
PO2 is slightly improving, but you can see PCO2 is going up slowly. So, do you
Okay.
think of changing your IE ratios at this point, or what would you do? Your driving pressure is already on the peak, like you don't want to go any higher.
Yeah, so again, that puts us in a difficult situation when your driving pressures are already up and your plateau's up. You really can't go up on your tidal ventilation. If you're looking at the IE ratios, we prefer to get them closer to a 1:1 ratio, right? More than anything. So again, I don't think changing the IE ratios would have any benefit. So in these patients who are prone and who are becoming hypercapnic and we cannot do anything about the respiratory rates, again, we go for extracorporeal therapy in these.
Right. How high permissive hypercapnia would you accept?
So it's based off of the pH rather than the PCO2 number for us. So again, it's institutional dependent. We prefer a target of 7.25, but we can accept any target between 7.15 and 25. But below 7.15, we absolutely do not. We send them for extracorporeal therapy after that.
Right. Go for echo, is it?
Usually not. I mean, Eco R, even though it's there, the problem is the ECOR machines, they basically run off the CRRT circuit. So if it's coming to that point, we usually just send them for VV ECMO rather than sending them for ECOR therapy.
Okay. Yeah, sometimes on ECMO as well, we have seen CO2 going up, creeping up, building up. So,
Mhm.
uh, would you combine VV ECMO with CRRT or put a filter to get the CO2 down?
So usually not. I mean, for us, of course, my experience is not that broad that I can, comment about it. But at least for us, with a higher respiratory rate on the ventilator, going all the way to like the 30s and having a high sweep flow on the ECMO circuit, we've never had issues. The other big thing that we look at, and something that I know that we don't look at there is we look at the rest. Our dietitians are pretty strong, so we look at the respiratory quotient, we look at the carbohydrates that they're getting, and we see if there's anything that we can do to reduce the respiratory quotient of CO2 in the diet so that we could potentially bring it down. But so far, from all the ECMO cases that I've seen here, we never had any issues with hypercapnia on the ECMO circuit because we've always been able to manage it with a higher respiratory rate and a higher sweep flow for these patients. So unfortunately, I do not know that because I've never experienced it so far.
Yeah, maybe because some of them we must have tried like your graph red and black, really high mortality, those kind of
Mhm,
cases. If you try, maybe you will see this kind of
mhm.
results. But
Yeah,
yeah, maybe not the usual where it's indicated early ECMO. You may not see this bad cases, right? Yeah.
yeah. We usually don't. But again, as I said, diet is something that we don't really keep a close watch on, and that contributes to hypercapnia as well. So whenever we see that, we have our dietitians look at the respiratory quotient of the tube feeds that they're getting, and we see if we could potentially do a different diet that has a lower CO2 emission, and that also helps sometimes.
Thank you. Thank you. Nice talk. Thank you.
Thank you.
Nishant, how
Any other
many
questions?
sessions of prone you will go for before ECMO?
So, how many sessions of Throne? Again, sir, that's not set in stone. The sessions we usually every single time we prone them, we see whether there's an improvement in the PF ratio or not. And every single time we put them in supine, we see whether they're able to come down to an FiO2 of around 50%, and if we're able to get them to a PEEP of 10 or below. So if that's happening every single time we do it, we encourage more sessions, and usually we try it for around 48 hours. With 48 hours, if we're seeing benefits, then yeah, we can go ahead for further trials. But again, beyond 48 hours, if there's no benefit of doing it, or if you do not have an improvement of your PF ratio after proning, we do not even go in for a second session. We just stop proning the patient at that time.
Okay.
Nishant,
Yes, sir.
so on behalf of Indian Chess Society,
Mhm.
we invite you as a guest faculty for the next NAPCON at Lucknow. So come
Sure.
with family to participate and also see Ayodhya there.
I hope I can come.
Yeah, you should come.
Yeah.
I don't know unless
Sure.
some
Thank
other.
you.
Okay,
Thank
thank
you.
you.
Hi, Dr. Nishant. Last but
Hi.
not the least, this is Dr. Varalakshmi.
Mhm.
So,
Hi.
really, I mean, congratulations. It was a very nice presentation, and we got to get a younger perspective. I think, we are
Mhm.
probably somewhere a decade or 5 years, prior. So, I can see the change in mindset as a young intensivist in you. And
Mhm.
what this class has essentially taught me is what we should aspire for. Of course, we are in the Jugado business here in India, because
Mhm.
we don't have access to, ECMO easily. Even proning is
Mhm.
a little challenging in some of our units, although it's not
Mhm.
a lot more prevalent now. But from
Yeah.
your perspective and from your confidence, I got to know what we should aspire for, and that I think we should
Mhm.
somehow slowly leave our Jugadu pun behind and then start pushing our administrators and our hospitals and train our
Yeah.
younger intensivists in ECMO and getting all the facilities which will help save vital and very important lives. So thank you so much for giving a fresh perspective and thank you so much.
No problem. I honestly think that the esophageal balloons are something that you should absolutely push for, because that's
Correct.
something that is very compatible, especially with all the Hamiltons that we have there. The I don't know what Hamilton vents are being used there, but the C6 is something that honestly connects really well with the esophageal balloons. And the cost of the esophageal balloon that we use is $100, so that's roughly like 10,000. So if needed, yes, I think 10,000 is a good amount if it helps the patient.
100% agreed.
Yeah. All right. Any other questions?
If you don't have
Okay, I
that
see.
Hamilton and esophageal balloon is available, can you have the separate monitor for monitoring this transpulmonary pressure? And what is the cost
Oh,
of it?
okay, so there's no separate monitor. The reason being you need to do your inspiratory and expiratory holds for the esophageal balloon. So to do that maneuver, unfortunately, it has to be connected to the ventilator circuit. So unfortunately, yeah, and it's not only the C6. I just gave an example of the Hamilton C6. It's compatible with a lot of the newer ventilators. I think along with the Hamiltons that we have. We some of the Macs that we have, those are also compatible. So unfortunately, no, there's no separate monitor because you need to do these maneuvers, and it can be done only through a ventilator. So the ventilator has to be compatible.
Yeah, right. Thank
Any
you
other
very much, Dr.
questions?
Nishant.
No
Explained
problem.
everything, all the questions you answered, and you have given a new perspective of mechanical ventilation and ARDS protocol, and what are the different options of management. So, if there are no questions, we'll close the session. Any final sum up?
Sure. I just see one question in the chat. There says somebody is asking if is it plateau pressure or tidal volume that's important. So both are interlinked. If the tidal volume, so your driving pressure, if you look at it, it's your plateau minus peak. And honestly, if you have to reduce your plateau pressure, your tidal volume has to go down. So unfortunately, I can't say which is important. Both are interlinked with each other. That's all I have to say. And closing remarks, as I said, driving pressure, quick bedside tool, please keep it in mind. And if your patient is becoming more and more hypoxic on your current ARDS strategy, please think of all the other causes of hypoxia. And that's what I'll leave you all with. So that'll be all, Dr. David.
What I understood
Okay.
about that question, his question,
Uh-huh.
tidal volume and plateau pressure. Even can
Uh-huh.
you go up to 10 ml per kg if the plateau is less than 30?
So theoretically, yes, you can. You can go up if the plateau pressure is less than 30. Because again, as I said, even with the ARDS trial, there was a slight increase in mortality with volumes of 8 ml per kg and above. But again, if that's keeping your plateau pressure below 30, it's okay. You can go up on the tidal volume.
So one of the advantages
And
of going up on tidal volume is you can reduce the respiratory rate and so mechanical power also.
yeah, agreed. And I see that there's
Particularly
one.
in patients ARDS with metabolic acidosis, we should think about that.
Yeah. So
Somebody
I
is
have
asking
one more
rota-prone beds and other
without rotapron.
normal.
Yes.
Any
Yeah.
difference?
So there's no difference in the way that there's no like decrease in mortality or anything like that. The difference between the rotaprone and this is without a rotaprone bed, you need a team. For us, we have a team of 8 people. We have, if we do not have a rotaprone bed, we have 3 on the right side of the patient. We have 3 on the left side of the patient. We have somebody who's watching all the IV lines. We have a team leader who stands at the head of the bed, and we have a respiratory therapist who's responsible for making sure that the ET tube is not dislodged or it doesn't move out of place. So it's resource intense. And then we flip the patient over. Despite doing that, there is always a chance that the ET tube might be dislodged compared to a rotaprone bed wherein all the equipment is secure, nothing moves. The rotaprone bed itself moves like a skewer on a grill. That's how it moves. So the only difference I would say is that it's less labor intense and there's lesser risk of ET tube dislodgement. But otherwise, there's no mortality benefit if that's the question.
Right, sir. Thank you very much.
Not
Thank you, all the audience. Thank you, Dr. Nishant, for excellent
Thank you.
presentation. Thank
Hi,
you, Ravindra
Nishant.
Babu sir, Prem Kumar sir,
Hi,
Hi,
and
hi,
Nishant.
Dr. Mohan
hi.
Maharaj for
summary.
who is
Uh,
anyway.
All right.
Auntie
Giving
from
the
Dr. Vani from Vizag.
Okay. Yeah. All
Nice
right.
to listen to you.
Thank you.
You
Thank you.
spoke like a debut hero, cinema hero for us.
Thank you.
Nice.
Thank you.
Best of
and
luck,
we request
Nana.
Dr. Nishant
Thank you.
to have some more presentations on this Morton group to
Sure.
benefit all the.
Whenever you need me, just let me know 2 to 3 weeks in advance, and I'll be happy to
Yes,
give you
sir.
more.
Yes,
All right.
yes. Thank you very much for that. And
Thank you.
thank you all the Dr. Prem Kumar sir, Ravindra Babu sir, Mohan Maharaj, and Mohan Rao for providing such a wonderful intensivist to give this presentation today. Thank you for that. Thank you, Dr. Nishant, and we'll close the session.
All right.
Thanks
Thank
to
you.
Morton Group. Goodbye.
Thank you.
Thank you, sir. Thank you. Thank you.